results in disparities within and among provinces, territories, and Indigenous jurisdictions where individual programs provide varying levels of drug coverage. This is what we call the postal code lottery. As a result, 1 in 10 Canadians reportedly do not take their prescribed medications due to out-of-pocket costs, highlighting significant inequities in access to necessary medications. Up to 7.5 million citizens, 1 in 5 Canadians, either don't have prescription drug insurance or have inadequate insurance to cover their medication needs, or do not enroll when eligible. But cost and coverage aren't the only problems. Here's the bad news for anyone in the Ottawa bubble. 64% of Canadians believe that the federal government is not transparent enough about its healthcare policies. This lack of transparency erodes public trust and hinders the effective implementation and uptake of health initiatives. Then there's data. Inconsistent reporting and lack of transparency in health data hinder the measurement of performance and outcomes, decrease opportunities of identifying gaps in data and services, and impede the capacity of the health system to integrate patient voices. There's also a lack of representation of patient voices within governments and government-funded organizations generating and implementing drug policy. One result is a healthcare system less responsive to patient needs. This can potentially compromise the quality of care and lead to a disconnect between patient expectations and the care provided. In addition, existing complicated patient pathways cause significant stress and anxiety for patients and their caregivers, potentially exacerbating health conditions and leading to worse health outcomes. 30% of Canadians experience difficulties in navigating the existing healthcare system, leading to significant delays in receiving necessary medical attention. Changes in pharmacare must not create new barriers to innovations to address unmet needs of patients. The involvement of patients should be done in more than an expedited and truncated consultation on such a foundational expansion of the social safety net of Canadians. Patients should be built into the programs in the structure, not just an occasional consultation. For example, patients, and that's plural, should be on the board of the Canadian Drug Agency. While we have 8 friendly recommendations for amendments to the bill, as a courtesy, I'm right at the clock of almost 4 o'clock, I think. If somebody could do us a courtesy, we'd love to have those 8 submitted. But I want to, and it's in our written submission, I want to highlight on 2 key points of patient interests. First, create a chief patient officer at Health Canada. And second, create a patient ombudsman who reports directly to Parliament. Only MPs and senators can make this ombudsman role come to life. The chief patient officer at Health Canada would work within the organization. It should be someone with lived experience whose role gives them authority to ensure the patient experience and expertise is recognized and used to drive reform and improve patient outcomes. This person should further be supported by an advisory committee with diverse patient representation, which this legislation doesn't quite contemplate yet. The patient ombudsman would work outside the organization and report independently to Parliament. Besides reporting on any failures to uphold the Act and regulations, this ombudsman would also assess barriers and concerns as expressed by patients when it comes to accessing medications and recommend changes. These amendments to Bill C-64 would enable and reinforce transparency and accountability. It's not enough for any government to say they want universal access to medications. Bill C-64 should speak to the role patients must take in improving equitable access to medications. With your questions, I'd be pleased to go into detail on all 8 of those proposed amendments we suggest to better support patients. The Best Medicines Coalition calls on Parliament to do its best for Canada's patients. On behalf of all patients, nothing about us without us. Thank you.
Thank you, Mr. Adams. We'll now begin with rounds of questions, starting with Dr. Ellis for 6 minutes.
Thank you very much, Chair, and thank you, everyone, for being here. It's certainly with interest that we'll pursue this next round of questioning. Without wanting to start a fight with Dr. Gagnon and Dr. Morgan, because both of your bios say that you're Canada's leading experts in pharmacare systems. So it's a good thing you're both not in the room. It might be interesting. But anyway, that being said, I'll start with you, Dr. Morgan. You've written 150 papers about pharmacare and how to implement it. I'm interested to know how much consultative time you spent with the government on this Bill C-64.
I was not directly involved in developing this piece of legislation or the bill at all. So I've worked with government, advised different people within the bureaucracy and government over many years, but I was not involved in drafting Bill C-64.
Thank you for that. And through you, Chair, Dr. Gagnon, were you involved in the drafting of C-64?
Absolutely not.
Okay, well, we've got two Canadian experts who had nothing to do with this. This scares me. So that being said, Dr. Gagnon, you talked about the universal healthcare system and a universal pharmacare system. Now, I was a family doctor for a long time. The Canadian Medical Association president a couple of years ago, Dr. Catherine Smart, said that the universal healthcare system is on the brink of collapse. So clearly we have a system that, for a whole host of reasons, is not working. It's not managing well. It's not being managed well. Why would we want to enter into a universal pharmacare system? Again, I'll even put myself in the same boat, whether I should. It wouldn't matter if it was a conservative government or a liberal government. Why should we trust the federal government to make another system that, in my mind, is probably just going to fail Canadians?
So when it comes to implementing universal pharmacare, doesn't have to be for the federal government to do this. That can be done at the provincial level. That can be done through specific agencies that are being put in place for this, through different type of social insurance systems. So you can have an independent agency taking care of this. But with the current fragmented system where there's no objectives, common objectives, massive waste, we have right now 100 different public drug programs. We have more than 100,000 private drug programs going in every direction, and you end up with a system that if you want to navigate and play the game, basically, doors are very much open for abuse, and this is what we're seeing a lot. So when it comes to cleaning up what's happening, a universal single-payer public system remains the best thing to do. Then you can have all the other players adding up with supplementary coverage, be it provinces being private payers. It's not an issue, but we need a solid foundation that works well, that is efficient, that works rationally, that gets us value for money, that also promotes a more appropriate use of medicine. And if we have these building blocks, then we can see in terms of in French we say la finition. Then we see basically what we add up over this, and we can build different things. But we need the solid foundation. It's not there right now, and we are not prepared with, for example, all these new super expensive drugs coming to the market. We are not prepared to face the music. Canadians are not prepared because we don't have these foundations now.
Thank you very much. And Dr. Morgan, I'll turn to you. The other thing that it appears is often, we've heard in the last couple of days testimony related to the length of time it takes a medication to get on formularies on behalf of Canadians, often thousands of days. We've got the Health Canada, PMPRB, CDA, CADA, PCPA, et cetera, et cetera. It would appear to me that it would have been also a good idea in this Bill C-64 to add some oversight of those agencies, specifically the newly formed CDA. Do you think that would be benefit here, or do you have some other ideas around the necessity to get drugs to market on behalf of Canadians?
A couple points. I'm glad you raised the issue around timeliness in terms of drug approvals and coverage decisions. Some of the evidence that's been cited in testimony in these hearings is concerning or from reports that start the clock, so to speak, when a medicine is first approved in any country internationally. So it doesn't take into account the fact that manufacturers themselves choose to delay the introduction of a drug into some markets for strategic purposes, but also because often they'll trial drugs in markets like the United States, Germany, or Japan, and then choose whether ever to even launch in other markets. Nearly half of all drugs that are trialed in that way don't make it to other markets, so that's important to know. As far as delays in approval times, I think there are concerns about making sure that Health Canada is adequately staffed and resources to make its timelines. There's also concerns about the fact that the fragmented system we have right now with CADF and the PCPA and then provincial decision making that follows it is one that does beget long delays in coverage decision making. And in fact, in that process, it is one of these processes that no means no in terms of the recommendations from the advisory bodies, but yes only means maybe, because provinces are not bound to complete the coverage equation. So a truly national program that is managed by an agency such as the Canadian Drug Agency or something like that was given the budget to manage and the task of making sure that there was timely access would be a system that would make sure that we don't have those kinds of delays.
Thank you.
It should be reasonably independent, but it should be accountable for performance.
Thank you, Dr. Morgan. Next, Mr. Nakvi, please, for 6 minutes.
Thank you very much, Chair. And I'll start my line of questioning with Dr. Morgan and Dr. Gagnon. You both are experts in pharmacare. You've studied this. Can you talk about the impact of the lack of a pharmacare plan on the general health of a population? And we can talk about Canada. What's the impact in terms? I'm assuming is negative, and if it's negative, in what ways does it manifest itself? Perhaps we can start with Dr. Gagnon, with you first.
That's an excellent question, and basically, lack of access is a very important issue. And low-income workers are normally the most impacted by this. Racialized communities in particular, based on surveys that were made looking at barriers to access, looking at issues of race, racialized communities was a big problem. What we see a lot, and this is something super important when we do all the budget and costing and stuff, because the PBO, something they did not include in all the costing, is how much money we would be saving in hospitals and emergency rooms if people can have the right access to the drugs they need. So keep in mind that the PBO report showed that we would be saving more than $2 billion a year, but also by extending by 13.5%. We will be increasing basically the amount of prescriptions by 13.5%. So this is 13.5% of people who need prescriptions right now and are not getting it. They are the people who end up in emergency rooms. And then this is for hospitals, because if you go to the hospital, then it's not the same budget. Your drugs are being paid for by the hospital. Other issues that for me is also very important when it comes to Social Security. It's just, if I'm in Quebec, I'm on Social Security, I will be gaining something like more or less $15,000 a year. If I try to go to work and start working, let's say 15 hours a week, because that's all I can do, I get access to my drugs with no premiums, nothing to pay, everything for free as long as I'm on social assistance. As soon as I want to get out of this, basically, then I need to pay huge premiums in Quebec. You need to pay your full premiums even if you're only working part-time. And if you're working only 15 hours a week, basically you end up with maybe $20,000 in terms of revenues. But then something like maybe $2,000 a year in premiums for your prescription drugs. And in terms of creating poverty traps, when Munir Sheikh, when we wrote this report about the reform of social assistance in Ontario, meeting with people, that was one of the huge barrier, the huge poverty trap. Basically, people end up with trying to stay in programs where they can have access to their drugs, because if you switch to at different stages, you might lose access and basically impact on your health, so morbidity and mortality. And maybe one last point on diabetes. There was a study 10 years ago basically showing if in Ontario only we had universal single-payer first dollar coverage for people with diabetes, basically that would save 700 lives a year. And this is amazing how much we're not doing anything about this, because it's not two planes that fall down on the street and everybody dying. It's just, oh, well, these are statistics somewhere. 700 people, they were sick anyway. This is not important. This is freaking important. So yes, these are some of the issues.
Thank you, and I appreciate your passion. Dr. Morgan, do you have anything to add to Dr. Gagnon? Any additional points?
No, other than to say this has been thoroughly studied, and the business case for making sure we have universal access to appropriately prescribed medications is unequivocal. It is good for the country's health. It's good for the healthcare system.
I want to come to Dr. Norman. Thank you for being here and bringing the perspective of Action Canada to this conversation. And on the same theme of cost savings in the healthcare system, can you talk about what kind of impact we can see from having universal access to contraceptives that's contemplated in Bill C-64?
Absolutely. Thank you for the question, and through the chair. As a family doctor who's been working in family planning for most of my professional life, I see regularly people coming in for recurrent unintended pregnancies where they do not want to be pregnant, they hadn't wanted to be pregnant, and they have no access to the ability to be able to manage their lives so that they can continue in their education or get out of a toxic relationship, or to be able to undertake the job training to move into a profession that they would like. And they're saddled again with an unintended pregnancy. Some of them will go on to ensure that they aren't pregnant through to delivery, but most will end up having to look after other children and then have childcare and other actions in their homes that make that take the time of their lives that they could have been using to advance the care for the children that they already have and for themselves and their lives. So I think when we talk about cost savings, we can show, and all over the world systems have shown, that single payer first dollar universal contraception coverage will be able to have better health outcomes and lower pregnancy care costs. But I think we have to look as well at the costs to our next generation and to the fact that they will have lower achievements throughout their lives due to the inability of their parents to have accessed universal contraception.
Thank you, Dr.
So that
Moore.
it becomes intergenerational.
Thank you, Dr. Norman. Monsieur Blanchette-Chonka, pour 6 minutes, s'il vous plaît.
Merci, Monsieur le Président. Je salue les...
Thank you very much. I'd like to thank the witnesses on the third panel. My first question is for Mr. Adams from the Best Medicines Coalition. In the recommendation 6, you said that the Minister of Health should create a special access path for patients so that they can receive prescriptions under specific circumstances of drugs that are not on the list. As you know, in Quebec, we do have a program that will pay for certain medications under exceptional circumstances. An example is, as a final attempt, what would be your recommendations on this matter?
Excusez-moi, je parle bien long, seulement un petit peu. I will do this in English. We've heard a lot about Quebec today. in the conversation. And thank you very much for the question, because it highlights one distinct aspect of Quebec which the rest of Canada should emulate. There will always be, the other thing we've heard a lot about, not every patient responds in the same way to the same drug. So we need some variety and some choice in that. And Quebec has a mechanism where a doctor can apply to a truly independent scientific review committee that is outside of the health bureaucracy for a drug that the doctor knows the patient needs, whether or not it's been approved by Health Canada, whether or not it's being funded through the existing system. And I come from a rare disease community, PKU, phenylketonuria. It's not life-threatening. It's only brain-threatening. I have a son with it who's a responder to the first pharmaceutical, and a true and a full responder. Every patient with PKU who's gotten access to that the first drug for PKU has been approved through Quebec's unique, exceptional patient program. There will always be outliers. What we need to achieve, working toward, is precision medicine, a molecule that works for the individual given that individual's genetics and biochemistry. We're not all the same. One size does not fit all. And it would be a great improvement for national pharmacare as a concept to always have that safety valve for the exceptional patient. And there's decades of working experience in the province of Quebec that we can all learn valuable lessons from.
Merci, M. Adams. Écoutez, j'apprécie.
Thank you very much. And I'm glad you recognize that distinction, because I think you know that it's not just when it comes to Medicare. We could probably carry out another study just on that topic, but perhaps that wouldn't happen at the Health Committee, maybe at some later time. Now, coming back to what you mentioned in your brief, you said that no patient in Canada should lose coverage because of reforms in C-64, and that these changes should not leave patients in a more precarious situation than before the reforms. Could you please explain your concerns?
We hear many concerns and criticisms of the model proposed in the version proposed in Bill C-64. I've heard additional criticisms from my fellow panelists today. And we're hearing mixed messages about whether this is such a good idea or not as proposed. I, as the parent of 2 sons and 2 daughters, I care about sexual reproduction and sexual health all the way around. And as I used to be pre-diabetic, I no longer am. So I care about medicines for diabetes. The drug that turned me from a pre-diabetic into non is not on the list as proposed by the Minister of Health at the moment. So those are specific examples. There's a great deal of uncertainty. And also, there have been, in previous government initiatives at federal and provincial, territorial, and Indigenous levels, there have been unanticipated or unintended consequences. And make haste slowly. I think the bill is a useful start, but I think this legislation is in need of and has many opportunities to be improved.
Monsieur Adams, vous mentionnez toujours dans votre mémoire une chose très importante.
You also mentioned something else very important, saying that the federal, provincial, municipal, and Indigenous governments should all work together and consult stakeholders. We must place emphasis on effective, simplified infrastructure in order to improve patient care with a high level of fairness and a wide scope of medication available to everyone, in a timely fashion. I completely agree with this. You have said that everyone needs to get the best possible care. With that in mind, don't you feel that the federal government should increase the health transfers to enable Quebec and the provinces to improve their healthcare systems and thus improve patient care?
Brief response, if you can, please, Mr. Adams.
I'm old enough to remember when Medicare was sold to Canadians and to provinces and territories on the general concept of a 50-50 cost sharing. We should take a look at that. All right.
Thank you, sir. Ms. Zarillo, please, for 6 minutes.
Thank you so much, Chair. And I just wanted to get some clarity from you before I begin my questioning. You mentioned that the time for amendments was a while ago, so just wanted to clarify that any input that comes today will not be able to inform an amendment. Is that correct? Yes.
That's correct.
Okay. So I just want to say what an amazing panel this has been, and so informative. And because it's not at this time able to have technical influence on the bill, I do have some questions just around equity and fairness, and I really want to focus on gender equity, because I think that if there had been more women in the government at the federal level, we would be a lot further along, certainly on contraceptive. So, Dr. Norman, I just wanted to ask specifically about getting results. So we know that BC, and you mentioned it, has free contraceptive now, and I'm wondering if you could share some of the arguments or factors that got the BC government to implement free contraceptive, because obviously it's something that I would like to see and many people would like to see right across the country.
Thank you very much, Member Zarillo, for your question, and through the chair. We were funded by CIHR to conduct a study where the Government of BC and the Ministry of Health were one of the partners in setting the research questions on the main research question and how to analyze the results so that we would be able to support them for what would be the impact of a system of subsidy for contraception on health and equity in BC. And so our study undertook, first off, a province-wide sexual and reproductive health survey, and this government in 2021 was able to use the basis that we made for that sexual and reproductive health survey to implement a sexual and reproductive health survey across Canada that we'll be fielding later this year, run by Statistics Canada. And I think that this is a key moving forward as we implement free contraception through this bill, in my hopeful way, to be able to measure the impact, because this was what BC used to measure the need. And this was how we determined where there were inequities and how those inequities could be addressed through universal contraception. So undertaking surveys of people and being able to look at health system and health administrative data in comparison with the survey data, and StatScan's new survey that will go out will also be linking with a personal health number to health administrative data, so that we'll get a specific disaggregated equity data on the gaps for people in achieving their sexual and reproductive health. The baseline in 2024, of course, will be before any impact of this bill, but I think it will be very important moving forward for the government to continue to have, as one of Statistics Canada's core surveys, a sexual and reproductive health survey that allows us to disaggregate and understand those equity barriers across Canada. I don't know if I've answered your question in the way
you have, and it's spurred on another question. And I mean, you've been working in reproductive health for a very, very long time, so I'm sure you have some indication of how those surveys are going to come back. But my question is around what factors do you think contribute to the difference in prescription insurance coverage described for the population overall and for those at risk of unintended pregnancy? Because I'm quite sure that you're going to get information about the disaggregated groups that have unintended pregnancy.
Yes, absolutely. Well, as you have heard from other panels here today, I'm hearing that experts in the insurance industry say 97% of people have some form of coverage. Well, we certainly are not seeing that in sexual and reproductive health. When our studies have looked at those presenting with unintended pregnancies, we find that up to 70% have no coverage at all. And when we've been able to look overall at the prescriptions accessed in BC through the pharmacy for people who have already accessed and purchased a contraceptive, 40% had complete out-of-pocket payment for that with no insurance whatsoever, and another 20% required a copay. This copay and not having insurance for that 60% of those accessing contraception doesn't even illuminate for us the wide range of people who weren't able to access contraception at all because of that inequity of cost. The people who need contraception tend to be those in the reproductive age range and the age of the highest fertility among women and people of any gender who are pregnancy capable. This age range doesn't have has one of the lowest rates of permanent jobs, of full-time jobs that offer coverage. There's a gig economy, people still in school, and the coverage through people of this sector of highest fertility has often is through a primary plan holder for coverage where they might have it, who has power over this person. And so they need to disclose their use of contraception is a barrier for people in coercive relationships, for adolescents on parents' plans.
I'm just going to interrupt you there because I want you to go on that one a little bit. So, I mean, I'm a female, and like many people, by the time you're 16, you're having conversations about having contraceptive and needing contraceptive. And I did make note of your questions or your comments about parents or coercive partners. Maybe you could share the risk that presents to teens and young, very young females in regards to that.
Yes. So as many of you are aware, the highest fertility rates are at the closest time to your teens and decline after the late 20s. In this age range, people are often still living at home, or if they are away from home, they're often in relationships, sometimes with a partner who is the person controlling their access to contraception or to funds. These individuals are facing so many intersecting barriers to achieve their own gender equality. They have to choose between buying a contraception or paying their tuition or rent or food. Clearly, the other three aspects are their first priorities so that they can continue on in their lives. And they'll use no contraception or a much less expensive method that has high pregnancy rates and present then with an unintended pregnancy that may stop their education altogether.
Thank you, Dr.
Prevent
Norman.
them from going into the workforce.
Dr. Kitchen, please, for 5 minutes.
Thank you, Mr. Chair, and thank you all for being here. It's greatly appreciated being it late on a Friday. And although our windows are closed, I have no idea what the weather is outside, but I appreciate you all being here at this point in time, and your presentations and comments. And as you all understand, ultimately we're looking at the legislation, and to me and to you, I believe, is that what can we do to make this piece of legislation better? What steps can you put forward and suggestions that we should be able to utilize, that we can make amendments if needed to this? And that's a huge challenge because as we've heard, those amendments have had to be in by 4 o'clock today. And so there's concerns as to whether they actually were put forward and will they even be passed or not. It's time will tell along those lines. But one of the things that I think is being sort of alluded to, but not really hit on the fact that healthcare is provincial. It's been touched on by a number of you that it is a provincial issue, and it comes to that aspect of the provinces being able to do what they need to do. And so my first question, to you, Dr. Gagnon, and you made some comments on looking at steps that could be done. And you did indicate or suggest, at least what I thought I heard you say, it could be done by at the provincial level. I'm just wondering, are you suggesting that we as federal government should be putting in legislation to tell the provinces that they should be putting in a universal health care plan?
Certainly, having some help from the federal government to implement this would be something that would make things way easier, I think, for provinces. You say healthcare is a provincial jurisdiction. I don't want to get into the legal stuff, but constitutionally, healthcare establishments are of provincial jurisdiction. When it comes to prescription drugs, this is more complicated because this is outside healthcare establishments. That's one thing. When it comes to drug approval, so this is the criminal law in terms of determining which substance is illegal versus legal, and if it's legal, what are the ways to have some access to it, so with the pharmacies and everything. So this is why we have Health Canada basically approving the drugs. And at the same time, when it comes to the pricing of these drugs, this is based on the Patent Act, which is also at the federal level. So like it or not, when it comes to prescription drugs, the federal government already has 2 feet basically in this field. It doesn't mean that the provinces shouldn't have nothing to say about this. I'm a proud Québécois. I think and when we put in place our pharmacare system in 1997, at the time, basically, it was perceived as a first step towards universal pharmacare. But what we put in place as a hybrid system, we kind of locked in all these commercial interests, basically, who can abuse the system in different ways. This is not normal that in Quebec, we are the 2nd place on this planet with the lowest cost, the highest cost per capita when it comes to prescription drugs. And that nothing is being done about it except, instead of containing costs, we'll just shift the cost elsewhere in the system.
I appreciate it, and I apologize for everything because I have such limited time. I appreciate that comment, but ultimately it still comes down to the provinces that need to make those decisions on what they believe, as Quebec has done, and every other province should be doing, which is what's best for them and their provinces. Mr. Adams, I appreciate what you presented and your recommendations and your 8 recommendations that you put forward. I think there's some good things about it. And ultimately, when we look at the legislation, the amendments, because we're dealing with this little piece that we have right now, the scary part is, will that grow over time? And ultimately, one of your recommendations that you did make, and I think in some ways it relates to what's talked about within, for particularly the national formulary, when we talk about the Canadian Drug Agency. And one of your recommendations, and I'll just read it to you, the Canadian Drug Agency must be established in legislation rather than at the direction of the Minister of Health, and subject to parliamentary oversight, the Access to Information Act, Auditor General scrutiny, and interventions by a patient ombudsman. And those are recommendations that are suggesting, in many ways, in particular for this agency, but also through what we've seen in the legislation where we talk about building a committee, but we have no idea who those people will be on those those roles. I'm just wondering if you could comment on that.
Briefly, please, Mr. Adams.
Thank you. And I don't know if there's procedurally any way to get an extension to 5 o'clock for those amendment guidelines. I toss that out there for what it's worth. This bill gives the minister substantial new powers. It could be improved by building in various forms of transparency and accountability, as I've said, and those are some of the things. And with all due respect, I think it defers too much to the black box called the Canadian Drug Agency, and doesn't put transparency or accountability mechanisms around what could become a very important role in system reform. All right, so that's the plea.
Thank you.
You're members of Parliament. Don't cut yourselves out of accountability and transparency. Build it into this legislation by amendment. Thank you very much.
Ms. Sidhu, please, for 5 minutes.
Thank you, Mr. Chair, and thank you all the witnesses for being with us, and thank you your amendments and submissions, submitting to the committee. Thank you, Andy, for your work. My question is to Dr. Norman, mostly question to you, because first of all, are you able to speak about the BC, the program, which it's a successful program? You have any data to share with us? I know it's a successful program, but can you share the data?
Thank you, members, Sidhu, and through the chair for a great question. I'm very proud of the work that we've been doing with the government of BC over the last 10 years to build towards this program. And I am working within the ministry under a non-disclosure agreement to assist the ministry to evaluate the implementation of the program. I have access as well to independent research we've been conducting at UBC on health administrative data. So I can share with you things that we've found on our own, but not the wonderful, amazing things that we're finding within the government in our own evaluation. So what we can see from the health administrative data access that we have through the university is that we have thousands of people requesting these new contraceptives and the most highly effective contraceptives since the policy was brought in place about a year ago in BC, thousands every month. In fact, we had such a surge and a sustained request for these most effective contraceptive methods that have been out of reach for people in their personal and household economy before this, that the BC media has been reporting on the wait lists and on the health system and service factors that now are being addressed to be able to meet this unmet need. But I think it's a very, when you can see, even the media can notice that there was such a high degree of unmet need in the province that the rush of people to access intrauterine devices and contraceptive implants, this match-6 size device that people can put in their arm has a lower rate of pregnancy than tubal sterilization, and yet it can be removed at any time and it can last for up to 3 years. People are rushing to be able to get these more effective methods that we've had before, rather than rates for birth control pills that might have nearly 100 times as many people pregnant each year than these more highly effective methods. So yes, BC has been a success story. We are super excited about the numbers that we're seeing from the comprehensive data within the government, and even from the data available in media reports and through the publicly accessible data we can access BC through UBC. It's a out-and-out success story. This is a way that people are now meeting their needs to be able to stay in school, to contribute to the workforce, to realize their own dreams for whether and when to have children and how to space them.
And Dr. Norman, what recommendation can you give to this committee on the education component during the implementation? How can we work with the provinces, territories, and Indigenous group on working with the young women, girls, their families, and potentially schools on raising awareness about the program? You talked about contraceptive stigmatization, and yesterday we heard about the teen pregnancy. So can you talk about that?
Thank you. This is a wonderful question, and I think it's a piece of the puzzle that we all need to pay attention to. I think, again, I would come back to the need across Canada for a comprehensive national sexual health survey that's iteratively and regularly administered so that we can disaggregate and understand where we can target education programs, where we can target outreach health systems that can get to those populations that inequitably aren't able to understand the knowledge, the methods, the services that they require to achieve their own reproductive health goals. And the ability to address a problem first needs us to understand it, and to understand it we need to measure it. And I think the baseline sexual health survey that will go out this year will provide a lot of data for the government on where we could be going, but it won't help us to understand how this bill and other future efforts that the government has made, the amazing work that the government's been doing to advance sexual and reproductive health through Health Canada, these impacts need to be measured as we go forward.
Thank you. Monsieur Blanchette, Jonca, pour 2 minutes et demie.
2.5 minutes, please. Thank you. I have more questions for Mr. Adams. Earlier today, some witnesses mentioned that we need to be careful because the expert committee will not simply have we need to ensure that it doesn't simply have a rubber stamp role. We need to ensure that they get appropriate information to give real advice and not simply act as an echo chamber or rubber stamp previously taken decisions. Do you agree? What are your thoughts?
We had many lessons recently from a little thing called a pandemic. And some of us took the time to observe the advisory processes in another jurisdiction, south of Canada. And when the CDC and the FDA advisory committees were whether they were dealing with vaccines, whether they were dealing with therapeutics, other things, they would have those. I could watch those on Zoom, and I could read the background materials. I could come to my own informed view. Did they get it, or did they miss it? When those advisory processes take place inside a black box, and you can't see, I welcome this opportunity. We're in public. People can make their own evaluations whether I get it or not. I can make my evaluation whether you get it or not, because it's open, it's transparent, and we can be accountable. When there's too much of the process at the federal level and at the provincial and territorial levels that take place behind closed doors and black boxes, it's time to, I would appeal to this committee to move amendments to start opening doors and opening windows and let the sun shine in.
28 seconds.
Monsieur Adams.
Mr. Adams, do you have anything particularly important that you'd like to add that we should do in order to make sure it's done right?
We've in our written submission, there are specific things there. I think you need to do your best to ensure that the freedom of information and access to information rules apply to the new model that this bill is trying to build for pharmacare, that there's accountability so that the Auditor General of Canada can go in and do value for money audits, and that there be a new function of an ombudsman so that people who think the system has not responded to them in a fair and reasonable way have an ability to access, without going to court, have an ability to access a review and oversight function, and that those officers and the health minister are required to report back to Parliament on a regular basis on steps, progress, and problems, and alternatives.
Thank you, Mr. Adams. Ms. Cirillo for 2.5 minutes, please.
Thank you. So I just wanted to ask Dr. Morgan, Dr. Gagnon, and Mr. Adams each. I only have about 30 seconds for each answer. But outside of this bill, each of you said something that I'm interested to know. Outside of this bill, Dr. Gagnon, you said institutional ripoff. What can we do to fix that outside of this bill? Mr. Adams, you said postal code lottery. What can we do to fix that? And Mr. Morgan, or Dr. Morgan, you said fairness and efficiency. So maybe I could start with Dr. Gagnon.
One example, Trintellix, SSRI antidepressant. So it came to the market, and CADIF at the time basically did the evaluation. There was no clinical evidence that this new drug was bringing anything more as compared to already existing drugs. And the recommendation, do not pay a penny more for this drug than the lowest priced drug of this category. Trintellix still entered the market with a price 10 times what it is for other drugs of the same category. I was reading annual report from the company Lundbeck saying, in Canada, Trintellix, this drug that doesn't have any clinical evidence that show any advantage as compared to other drugs, we did manage to capture 24% of the antidepressant market in Canada. So in terms of ripoff, if we have a system that says, you can make a commercial blockbuster with a drug that doesn't bring anything new, and basically the message you're sending in terms of incentives for innovation is don't innovate. We have a crappy system that will take in anything at any price. And this is what, in terms of institutional ripoff, this is what is missing in terms of getting value for money.
Thank you. Mr. Adams and then Dr. Morgan.
The postal code lottery, I have to give credit where credit's due. It's not my line. It's the line used by the immediate past federal Minister of Health, Mr. Duclos, in March of 2023, when he announced the go forward of the plan for drugs for rare disorders. I was there. It was ad-libbed by the minister. It wasn't in his prepared text. But it captures the essence of some of the inequities in the lists of drugs that are or aren't covered in various jurisdictions. And I think there is a compelling role for the government of Canada and the Parliament of Canada to make financial contributions so that access gets not to the lowest common denominator, but to a much higher common denominator for all patients, no matter where they live, no matter what postal code in Canada they're in.
Thank you. Dr. Morgan, hope you have time there.
No, you don't, but if you can answer very briefly, we'll allow that.
Yeah, I think that what you do is build national capacity to procure with ironclad contracts with manufacturers medicines of proven safety, efficacy, and value. Essentially, we need to implement the recommendations of the Hoskins Council.
Thank you very much, Dr. Morgan. Next, Ms. Roberts, please, for 5 minutes.
Thank you, Mr. Chair. So I'm going to ask yes or no questions to everyone. So I'm going to start with Dr. Gagnon. Do you think family doctors are crucial?
Crucial?
Like they're important to society?
Yes.
And Dr. Norman?
Well, as a family doctor, I think I have to declare my conflict of interest, but I would
Okay.
say a resounding yes.
Okay. Dr. Adams?
Yes, thanks for the promotion. Yes.
Dr. Morgan?
Yes, alongside of other primary care providers.
Okay, so I'll tell you why I'm asking this question is in Ontario, that's the province I'm from, we have 2,500 shortage of doctors. Over 2 million people don't have doctors. And by 2026, it'll be 4.4 million people without a doctor. 1.7 million people in Ontario alone have a family doctor that is over the age of 65. In Canada, 6 million Canadians who don't have a family doctor. And the reason I bring this up is a couple in BC, Jane and Steve Williams, have been on the waiting list for 3 years for a family doctor. He just recently went in for emergency surgery, and he has no family doctor that will be able to help him. So here we are, we're talking about pharmacare, we're talking about, taking care of our patients. How can somebody get the required medical attention and have the drugs prescribed to them that they will need? So I'm going to go back to Dr. Morgan, because you made a statement earlier, and I just want to make sure I get this right. You made a statement earlier that this is a patchwork system, and I have to agree with you. I don't think that this system was well thought of, and if I understand correctly, Dr. Norman, you said you were part of the panel. Is that correct? You're part of the pharmacare investigation with the panel with the government? No?
Oh, Norman.
Oh, okay. Sorry. Okay.
No, I wasn't part of the pharmacare panel.
And were you, Dr. Norman?
Part of the panel
to develop the pharmacare plan.
I worked with the BC government to be able to provide evidence that supported their development of their plan for contraception, and at the request.
But were you part of the plan federally?
of the Minister of Health in BC, I was able to present to the Minister of Health federally and other federal departments.
All right.
But I provided evidence. I wasn't part of their internal process to develop the bill.
Okay, so we have experts here that were eliminated from that. I'm a little confused about it. But Dr. Morgan, this patchwork system that you mentioned earlier, I have to also question, how is it that this pharmacare will benefit Canadians?
Well, one of the things is if we move to a system that is truly national, universal, single payer, Canadians will have increased access to medicines from coast to coast. We can use national procurement contracts to get better prices of medicines. We can use those same contracts to make sure that manufacturers guarantee the supply of medicines when Canadians need them and when we know shortages are all too common internationally. And it's true that if the federal government was actually to fund these first stages, contraception and diabetes treatments, and was able to leverage the purchasing power nationally to just get the average price we find in comparative countries, that system might cost actually more than the PBO is estimated, but it would deliver savings to the provinces and territories on the order of about $1.3 billion per year.
Okay,
it would deliver savings to the private sector of $1.7 billion per year, and net savings to the country of $700 million.
Okay, so I'm sorry to cut you off, but I do have limited time. So my concern is Bill C-64, in its current state, does not give specific enough information to ensure that this plan will benefit Canadians. And unless I misunderstood you, that's what I took from your statement.
This plan will provide some new coverage, but it will cost significantly more than it should, and it will continue to impose inequitable financial burdens on individual households and employers.
So would you agree that individuals with private health care and private plans are better off than the current plan that the government's offering?
They're not better. There's no change. That's what the minister basically said yesterday in testimony, that they'll just have the same coverage through their private insurance under this new plan. What we want to see is a change where they can actually see their medicines being procured nationally through a public program that takes the financial burden off their households and their employers.
But right
That's
now,
not what this bill will achieve.
Thank you,
Exactly.
Dr. Morgan. Thank you, Ms. Roberts. And the last round of questions for our examination of Bill C-64 will come from Mr. Joe Harry for the next 5 minutes.
Thank you, Mr. Chair, and I thank all the witnesses for joining us today well into the Friday afternoon. I know it's past 4 o'clock, and most of the amendments, probably it's already written down and passed on, but I want to emphasize the fact that this bill will go through clause by clause on Monday. It will be sent back to the House, and we have the opportunity to be able to debate it, and it will go to Senate. And that presents more opportunities for us to be able to highlight areas that we could strengthen it. I'm going to focus most of my questions to Dr. Morgan. I noticed you were patiently waiting, and a number of times you wanted to intervene, and you were not given the opportunity. So I'm going to dedicate all my 5 minutes or so that I have to you. You're very complimentary about Hoskin report, and you also said that if certain elements are considered in the design, then this bill C-64 would be a good starting base for us to introduce, pharmacare. Can you summarize, if I'm getting up on next week in the House and debating on the third reading around those areas and using Hoskin as a base and say, hey, look, this is reality of C-64. This is the base in a Hoskin. And these are the 3 areas that I want to focus to make sure that this bill is strong. What would those 3 areas be? And you have all the time that you want before the chair stops you.
Yeah, so I'll be quick. There are just minor amendments to sections 4 and 6 of C-64 that would probably suffice to make sure that even though this is just like baby steps, the pilot project for implementing Hoskin's recommendations, if you make a couple of key amendments, you can genuinely say that this legislation was actually going to do what Hoskins said. So, for instance, in Section 4 of the Bill C-64, the minister, it says the minister is to consider the following principles. And I think the Conservative members of this committee pointed out that that's unusual language. It should say the minister shall apply the following principles. That's important language. On Section 4(1)D, it says shall provide universal coverage of pharmaceuticals, but the Hoskins Council was very clear it should be universal, single-payer, first dollar public coverage. So there's language there that could be improved and clarified. As was discussed yesterday at this committee, this bill should define what is meant by single-payer, first dollar, and public coverage. Those are terms that are very clearly defined in the Canada Health Act, which would be the analogous act to C-64 in terms of establishing principles